Hello, everyone, and good morning. Good morning. Welcome to the Optimizing Incentives Summit. We are thrilled that you are here. We are going to go ahead and just get started with the summit. We know that we have a packed two-day agenda, and we are very excited to dive into all of the agenda today, as well as what we have in store for you tomorrow. My name is Maura Little, and I am the Executive Director of Cambia Grove. Now, a lot of you know Cambia Grove, but for those of you who don't, Cambia Grove is a healthcare innovation hub. We are focused on advancing impactful innovation to support a more person-focused and economically sustainable system. So why are we hosting this summit? Recently, we developed a new framework. It's called the Healthcare Innovation Advancement Framework. And the framework is really built on three components. It's the idea that we all want to achieve the triple aim or the quadruple aim, or just change in the healthcare system. In order to get to that change, we need to advance innovation. For us, the definition of innovation simply means change, but we don't want to just advance any old type of innovation. We want to advance impactful innovation. And what we've seen out in the community and within our ecosystems is that there are three ecosystem elements that need to be optimized in order to advance that impactful innovation in order to create a better healthcare system. And those components fall into infrastructure, incentives, and culture. I will get into a little bit more of those key ecosystem elements as we get on with the summit. But today we squarely fall within that incentives bucket of infrastructure, incentives, and culture. So within the framework, optimized incentives are critical to the advancement of impactful innovation in healthcare. Our goal today is to build upon the years of experience in this space by all of our speakers and all of our attendees. You all bring such a wealth of knowledge, and bringing those new perspectives to the table to catalyze further action. We have been working in the space for the past couple of years now, and I'll just name a few of the different events and programs that we have taken on recently. Last year, during Cambia Grove's Spring Pain for Health series in 2020, we brought global, national, and community thought leaders to the virtual stage to discuss how to improve health outcomes and how to align stakeholder incentives with those outcomes. We had some really robust conversations, and they're all online, and you can watch them via our website if you're interested in diving into those discussions. A couple of strong takeaways emerged from those discussions, leading to an overarching problem statement and key considerations for the solutions we need to develop as an ecosystem, as a community, as innovators throughout the healthcare system. In January of 2021, actually it was in February of 2021, Cambia Grove hosted its first ever hackathon, challenging the teams. We had 10 teams of roughly 10 individuals from across the healthcare spectrum. We challenged them to develop care and payment models that align incentives with health. That discussion and those resulting solutions laid the foundation for the topics that will be covered in today's Optimizing Incentives Summit. And so as you can see, we are building upon a lot of these conversations throughout the last couple of years, and we are thrilled to be able to bring all of them together for this two-day summit to explore this topic. And so we are here today, and Cambria Grove is thrilled to be able to build this summit with some incredible partners. Our partners, if we can go to the next slide. Oh, excuse me. No, we have our partners up here. We're thrilled to partner with the Accountable Care Learning Collaborative, America's Health Insurance Plans, the Pacific Hospital Preservation and Development Authority, and Patient Order to bring these conversations to the stage. So, a couple of things and couple of frameworks for the summit. We've built the summit to cover the history of incentives, the current state of how the system operates, and we'll conclude with actionable steps for the pathway forward. And those actionable steps and pathway forward will be covered in tomorrow's section. This is the housekeeping portion. So you should have received an attendee guide via email. If you did not receive the attendee guide via email, please email Nick Jackal, which is nick@cambiagrove.com. This attendee guide contains the links you will need to access each session, as well as information about our speakers, partner organizations, and the case study information for the Accountable Care Learning Collaborative peer learning sessions, which will happen tomorrow. So again, this attendee guide is something that you will refer back to throughout the days. Each of the sections that we have are in different Zoom links. And so keep this attendee guide handy, and also make sure that you keep track of what time these sessions are scheduled for. Also, a couple of things is that the larger sessions will be recorded, but for example, the 5 points of healthcare breakout session in the afternoon, those won't be recorded. And those are your time to really dig in deep with the speakers and get some of your questions answered. So each segment includes time held for audience Q&A. For audience Q&A, please use the Q&A box at the bottom of your screen to submit your questions. Again, I'm going to repeat that. The Q&A box is at the bottom of your screen. Please use that box to submit your questions. For most of the sections, I will be hosting the Q&A, and we'll try to get to as many of the questions as possible. Also, one super exciting thing that we have planned is that we have hired a graphic recording artist. Sarah Goon from Ink Factory is here to create live visual notes. They will be turning our words, Sarah will be turning our words into images and text to visually represent key concepts and themes of our conversation. So one thing to note as you get yourself set up in this virtual way is that when Sarah's screen is being shared, please feel free to adjust your view. If you are a visual learner and want to watch Sarah work, you may slide your screen to make the art larger. If you are an auditory learner, of course, slide the screen to shrink the view of the art. Make sure that you play around with the Zoom settings to optimize your experience here today and tomorrow. Finally, we wanted to share a glimpse into the broad range of organizations who will be in attendance throughout this event. We are thrilled to welcome each and every one of you and look forward to your participation and feedback. What we have learned throughout this virtual setting is that there really is an opportunity to stay connected virtually, but it of course takes a little bit more intentionality. And so we've built this summit with that in mind to try and make sure that there are different breakout sessions and breakout opportunities to connect with each other. But with this event and with many of the Cambria Grove events, we are just thrilled to see such a diverse segment of the healthcare innovation landscape all come together to talk through some of these challenging topics. All right, so if you have any questions about the logistics or the goals of this summit or anything that I just said, please feel free to type them into the Q&A box at the bottom of your screen. And I think that does it for opening remarks. So let's go ahead and get started. First up is our keynote speaker, Amy Bassano. Amy is the Deputy Director of the Center for Medicare and Medicaid Innovation, or CMMI, at the Centers for Medicare and Medicaid Services. Amy has a distinguished career in public service and will be kicking off our two-day summit to discuss the administration's focus on aligning incentives with health. If you are interested in learning more about Amy, her full bio is located in the attendee guidebook. It is now my pleasure to welcome Amy to the stage. Amy?
Thank you so much, Maura. I really appreciate that introduction and for you having me here today. I'm excited to share a little bit about what we are doing at CMS and how we've been thinking about the movement to value and sort of aligning those incentives, as Maura mentioned. So I have some slides here. I'll sort of run through a little bit, as I said, about what we are doing and thinking about where we've been and where we are going, although given that it is the beginning of a new administration and we have had a new CMS administrator for about not even quite 10 days, some of those things are still in process, but always stay tuned for that. But next slide, please. So wanted to start out by sort of grounding everyone in who we are and what we do with the Innovation Center. We were created a little over 10 years ago as part of the Affordable Care Act to test alternative payment and delivery models, looking to ultimately reduce costs and improve quality in our, the services that are provided under Medicare and Medicaid. The authorities are slightly different between the two programs, and I'll talk more about how we've been able to do work in those particular areas, but sort of we all come back to this sort of statutory authority in terms of what we can do, because there is so much to be done in the healthcare system, in the payment and delivery system realm, but we have, we at the Innovation Center are grounded in this. Although we have partners across the governments with states, other providers who can fill in and do more. Next slide, please. And so this really is sort of defining what we do, of what we mean by innovation, because it can be done in so many different ways. These alternative payment models, which reward healthcare providers for new ways of delivering cost-efficient and high-quality care. And so we sort of group them in a number of different ways of like conditions, the episodes of provider types, the community, and innovation in parts C and D. And I'll give a taste of the different models in these particular areas and how we've approached them. And then this is sort of always the important thing. Technology solutions and care redesign are important, but they're outside of the specific work. So that doesn't mean that we don't touch on it. Oftentimes partners, our participants in our model may be incorporating particular approaches to redesign care. We want to give lots of flexibility or, to use the appropriate technology, but we're not necessarily prescriptive or testing a particular specific technology. We always joke, like, people come to us and say, I've got an app and they're really great, but doesn't really make a particular model. Next slide, please. And so this is just a reference of all of our models that we have done. The blue ones are some of the more recent ones that we've announced, and really just putting up there for people's references. Like I said, I'll get into a couple of the key models that may be sort of good examples of some of the work we are doing. Next slide, please. And this is really just a reference. We used to have individual dots for every location, but the map got completely full. And one of the things, I put this up here because I'm really excited about it. I've been at the Innovation Center for 6.5 years, so more than half of its tenure. And the way our work and the sort of movement to value has spread so quickly and the adoption across the country. And so we've been in all 50 states across the country, all sorts of providers, all state work, Medicare, Medicaid work, and it has been really rapid adoption. But that is some of the tension we have now of 10 years in of the adoption has been fast and broad, but has not been entirely adopted. And there's still a lot more work to do in terms of the movement to value, moving away from fee-for-service, making sure all the incentives in the healthcare system are aligned appropriately. Next slide, please. I think this shows, yes, the number of people who've been in our models. These numbers are a little bit dated now, but more than 26 million patients, beneficiaries between Medicare and Medicaid have been in our models, and going on 1 million providers who have participated, mostly on a voluntary basis. And we are very excited for those who come and join us in this effort. But I will talk in a moment about what that means for voluntary and what some of the potential downsides are when we're only looking for people who are voluntarily willing to participate in these new arrangements. Next slide, please. And so we've spent a fair amount of time this past year or so thinking about our 10-year anniversary and how do we how do we become successful. And so one of the things we do is each of our models by statute has to have an independent evaluation to assess the impact of the models. And it really helps us think about what works, because there's often is either anecdotal evidence or people think it's working, but how is it working? We need to assess how is it working broadly in the healthcare delivery system overall, and not just for those who've self-selected in. How is it compared to to the comparison group of people who are not having this intervention? And one of the interesting things that we've have observed as we've this movement to value has gone on is, or becomes harder and harder to do that evaluation. We have very talented researchers who work with us on this and can tease out those effects. But when you're thinking about the overlaps of multiple models or multiple approaches that are being done, or even the spillover effects of having an episode and really changing, for example, the way post-acute care is delivered. And so we make sure we're teasing out that these really are effects of our interventions, similar to other types of clinical trials, whether it be in other areas of healthcare. And then there's a lot of conversation about what our portfolio should be and where we are going to invest, because as I said before, there's a lot of different ideas, a lot of different ways and potential opportunities to improve the system, but thinking about where we can get the largest return on investment for what we are doing, given we are running national programs. And we've had a mix of different sort of more local, more national, provider focused, state focused over time. But that's sort of always thinking about where have we invested to date, what's been that return on investment, where do we think we can continue to make progress. And I often talk about some of the earlier models I personally worked on, they were designed at a point in time based upon what we knew and where, meeting people where they are, and what we designed 5 or 6 years ago is going to be different than what we could design today, both because, the state of medicine, the delivery of care has changed. Certainly, COVID has changed us all and how we work and interact in that environment, but then also, lessons learned and our partners were all continuing to move forward. And so this is a continual evolution of our efforts and, continuing to try and refine and build those incentives in so that we are getting to, the higher quality care. And then just a point on this last part of the slide about expanding the duration. I said these are tests, but the ones who are deemed successful by our evaluations, we do have authority to expand them to sort of test them more broadly. Next slide, please. And so this gets to some of the lessons learned of our past 10 years as we've been reflecting from the both under the previous administration and now under the current administration about what has worked for us and where have there been some pitfalls. 6 of our models have achieved the statistically significant savings. 4 have gone on. We've gone on to expand or in the process of expanding, but voluntary models are great when we have early adopters, people who want to come in, but there's also a fair amount of adverse selection in those voluntary models. And so what does that mean for us? It means that we need to, the results may not be completely generalizable. It means that you can come in as you want, you can leave as you want, but as a test, from a rigorous scientific perspective, it may not be as useful for us to get to, sustained and nationwide change. And so thinking about using more mandatory models instead, especially in particular areas that we think there could be the adverse selection can be particularly acute. Benchmark accuracy is again some pretty technical issues, but if you're looking at folks who are in total cost of care models, what are we comparing against, and making sure that comparison is correct so that there is real savings being achieved. The quality measures, I think, is really important and a big focus of ours going forward. There has been a lot of focus on the cost savings, but we don't want to forget the quality aspect as well. And so to that end, we in CMI have been working very closely with our colleagues across CMS on making sure we have the right quality measures. We can measure the improvements of quality in these models, and that is just important as part as the cost. And to sort of, I'll talk a little bit about going forward, but I can't not say here the part about equity as well, that our leadership is very concerned about making sure we're addressing health equity through our models, and that it's through the quality measures, but it's through a number of other ways where we would want to get at equity and ensure that the models are both from an equity, achieving equity from a patient perspective, a provider perspective, and that really will be a continued and significant focus. And then data transparency. We know our participants need the information to be able to be successful, to get the claims information, to get other pieces of data that are helpful for them to do their models, but also for us to show how we came to our conclusions. What did we do? Being more transparent in our operations in general. And so some clear lessons we've learned and some, ways we're going to try and improve on those going forward. Next slide, please. And so quickly, I'll highlight some of the models that have been a success that we've deemed successful. Our ACO investment model, which was upfront funding for shared savings programs, and ultimately we returned on our investment that we got the savings to Medicare for new organizations going into MSSP. Many of our models have had some upfront payments, but have not been successful, meaning that we've spent money to incentivize particular services, but have not seen that return on investment. Our Pioneer ACO model was our first ACO model, and that achieved one of our first models to achieve savings and became part of the Medicare shared savings program. Our YUSA diabetes prevention model is our now has been expanded, our first sort of official expansion under rulemaking, and it provides a benefit for Medicare, pre-diabetic Medicare beneficiaries to engage in this program to lose weight and maintain that weight loss, which shows a reduction in moving on to full diabetes. So that is something that operationally has been a little more challenging, as we brought in very specific types of suppliers to provide that benefit. And so something we are thinking about of how do we, in general, partner with folks who may not be traditional healthcare providers, but have something really important to offer, and what is the burden, and how do we engage with them, and how do we then recruit the patients as well. So a lot of interesting lessons learned there that we're continuing to evolve and refine that program. Next slide, please. Maryland all payer. This was a global budget in the state of Maryland that was successful, that we have now a sort of a follow-on model, not looking only at inpatient services, but all healthcare services in the state of Maryland. And they have some targets that they're on track or obligated to meet in terms of savings. So in terms of state-based models, we have a number of them, and they're all sort of slightly different. So it's been exciting to work with the individual states to see what can meet their particular needs. The next one is the repetitive scheduled non-emergent ambulance transport. It's a prior authorization model that we ran in conjunction with our colleagues in the Center for Program Integrity for the very sort of geographically targeted for services that should not have been being provided, and just making sure that essentially the law was being implemented as it should have been, but achieved a considerable amount of savings. And now we are have certified it for expansion. And our most recent expansion announcement is in home health value-based purchasing. Many of the other provider types have value-based purchasing incentives, so hospital, SNF, and others, and that's by law, but home health doesn't have anything to date. And so we ran a model here in a select few states and found that it was achieving savings. So we announced earlier this year that it was certified for expansion, and now we are going through the rulemaking process of doing that particular expansion. So stay tuned for more details on that. Next slide, please. And so this is just another sort of lessons learned. Early models where there was limited financial risk. I mentioned, more payments, upfront payments or incentive payments provided to participants, but they weren't always really showing that return on investment. And so our newer models I talked about the quality reporting, shared savings, meaning, there's two-sided risk, and then also the integration of treatment and social services. The social determinants of health is also a really important part, and I'll talk about one of our specific models there. Next slide, please. And so just to touch on a few more models and thinking about how we're trying to align incentives. Primary care is an area that we have been investing in since the very beginning of the Innovation Center. Primary Care First is our newest model that builds upon two prior models, really trying to think about paying differently. There's increased financial risk, but more in exchange for that, there's more flexibility and more performance-based payments. Trying to think about how to incentivize primary care services practices to really transform themselves, and to think about the patient over a longer period of time, and what services they need. Do they need the referrals to the specialists or not? And giving them some flexibility there. And so there's a couple of tracks on that. Especially with a particular focus on high needs populations who are particularly expensive and complex. So wanting to make sure that the providers, that the primary care practices are paid appropriately for taking on those more complex patients, and really trying to, you'll see there the goals of reducing spending by preventing the admissions, hospital admissions, but improving the quality of care for the complex chronic conditions and serious illness, because we know there's a lot of opportunity there for savings, those small part of the population, but high cost expenditures. And so we started this model earlier this year and have another cohort that will be starting next year. It's really for advanced primary care. It's more complex work. It's more, not all practices are ready for this type of arrangement, but really trying to work with them to deliver this care. Also should mention, this is one of our models that are multi-payer focused, and primary care in general, since the beginning of the Innovation Center, has always had a multi-payer focus, recognizing these practices, if we're asking them to change, they should have sort of incentives all aligned from all of their other payers. And so we have a number of partners here in Primary Care First who are working with us, and they're sort of adopting similar payment structures, so that the practices have a consistent source of payment, and sort of back to the aligning the incentives, that they're all sort of going in the same direction. Next slide, please. Direct contracting is another new model of ours. It's a ACO-like model that started in April of this year. Again, sort of different tracks for organizations on what they're willing to accept in terms of their level of risk and the payment arrangements. Also, it's sort of I said as an ACO model, but really trying to bring in also new entities into the program who may have not been in any of our models to date, trying to have them come in, give them flexibilities to design the care for their needs. And I should mention that our models have, or our authority is to give us waiver authority for payment requirements, fraud and abuse requirements. And so our models have a number of waivers, or you may call them benefit enhancements or benefit flexibilities, to give these organizations that participate in our models, flexibility to redesign the care or to deliver the care in a variety of different ways. Prior to the public health emergency, we had, we could do a lot on the telehealth side. We also had a number of flexibilities. Each model is slightly different, but flexibilities for home-based care that may not have been available in fee-for-service. And so wanting to expand those or have more flexibility sort of the higher up you go in terms of your level of risk, and really giving the entity flexibility to ensure the patient gets their care, but how they can do it. And so home-based care is definitely one of the areas we're hearing a lot. What are their non-medical needs? What does their home need? Lots of visits to the home, fall risks, food insecurity, things like that. Are these participants, especially in direct contracting, now have flexibilities to do that. They're held accountable on a number of different areas, but we want to give them the most flexibility as possible to deliver the care, and that recognizing that a direct contracting entity in one part of the country may be doing it very differently than in different part, rural versus urban, the different populations. And so we don't want to be particularly prescriptive. We just want to set the parameters so that the organizations can really deliver the care of what they need for their particular patient population. Next slide, please. And then this is one of our new models, but it's an ambulance-based model. And it's was one of those where, when I mentioned earlier about thinking about our portfolio of, what areas have we touched? And we obviously had not done anything in ambulances, but there were some clear, incentives that were not right. The ambulances were getting provided, paid to provide services to transport to the hospital, whether or not the patient could be, treated in place, could be treated, an alternative destination. So we designed this model to allow that transportation to an alternative destination, whether it be a physician office, urgent care, mental health facility, treat on the scene, or go to the hospital. And so we, with the idea of making the EMS systems more efficient, and have had lots of really great response on that and interest in participation. But once the COVID came along, a lot of those flexibilities that were only available in our model became available through the public health emergency flexibilities. And so we are now looking at this model. The model is running, but thinking about, how will this continue after the public health emergency ends? We will always continue to have those flexibilities, but people have gotten comfortable with some of these flexibilities. And so in general, the agency is thinking about what flexibilities can continue that we've tested under the PHE. Now, could it be done in Medicare, into CMMI models, or will Congress act? And so I think, we're spending a lot of time thinking about, as I'm sure you all are as well, after the PHE, what does, services look like? What should CMMI be doing? There have been a number of areas that had waivers under the PHA, or have waivers that we had never gone there. We had never gone to removing the homebound requirement for home health services, or a number of other places that have been done. And so now we're evaluating and thinking about how can those be incorporated into our models. And then of course, if the laws have changed and things are different, do we even need our models anymore, or is it something that's now part of regular current law and is not a model is not tested? So things we continue to think about. Next slide, please. This is really, we have our kidney care choices model. We have again, another area we've been investing in since early on, and that's, kidney care services. Medicare pays for the vast majority of dialysis. And we had an ACO that looked at dialysis patients, our CEC model, but now starting next year, we have another model that sort of takes the place of that and builds upon that, a variety of different options for both dialysis providers and nephrologists, and hoping to treat patients downstream of dialysis to keep them from going onto dialysis, or at least if they have to go into dialysis, make it more planned, use home dialysis, transplant. And so there's a variety of options here. I won't go into all the specifics, but more of like, as we think about these things, I think that, we started with dialysis, but, where were the incentives? The incentives really should be for home dialysis, transplant, keeping people off dialysis. And so it required us to go downstream and to think about this differently. This is also part of a broader HHS push in the community at large on better dialysis care. And it's something that we CMI can't do on our own. So it's been exciting to work with my colleagues across CMS and across HHS on a variety of other different regulations and programs to try and really all drive to this. And, CMI can do our part through the payment models, but our colleagues across the department can use their authorities and levers as well. So we're all trying to get to that better place. Next slide, please. And our chart model, so another area of investment in terms of rural health. The applications for this first track of the community transformation track closed a few weeks ago. We are excited about that, which really, I talked earlier about delivering care differently depending upon your particular area. We know that rural services are not all the same, and rural communities are all very different. And so wanting to, allow these communities to come together and come to us with proposals about how they could better deliver care. What would an alternative payment model look like in their rural community? And so we are now evaluating those applications and hopefully we'll have more to say on that in later on the summer, early fall. We also have an ACO transformation track that we put pause on, but sort of building off of the AIM model I mentioned earlier. Can you do things to really build out the ACOs in the rural communities? Next slide, please. And a radiation oncology model I mentioned because this is our newest mandatory model. It is scheduled to go into effect sometime next year. Congress stepped in, sort of kept us from implementing it last year, but we are, said not until next year, and we're going through rulemaking on the actual implementation of that. But this is a model where, again, talking about the incentives, there were incentives to provide, the financial incentives for particular modalities of radiation oncology, the potentially overutilization of fractions of radiation that were not necessarily evidence-based. And so this is a model that tries to say, like, here's your payment for this particular cancer type. It does not look at the particular modality. It doesn't look at the particular site. And radiation oncologist and medical oncologist and patient all can work together to find out what's best for the patient, but we don't want to have payment incentives that are encouraging some suboptimal care. And so we worked with the, Congress originally asked us to do a report to Congress on this particular area. And it's something that we've been thinking, we all, CMS, Congress, and other stakeholders have been thinking about for a long time about, how do you provide the best high quality care radiation oncology services, especially as, evidence is quickly evolving, ever evolving in that space. Next slide, please. And I mentioned social determinants of health earlier. Our accountable health communities model is sort of our first step, or dipping our toe, as I like to say, in that space. It is coming to an end. So I mentioned earlier about we designed something at a point in time. This is definitely another area where the evidence has been evolving. The people, the organizations working in this space have, grown exponentially. The sort of wanting to do more work and the recognition of how important this is has evolved over the years. This really helps to facilitate organizations to get patients from, through the clinical setting to get them additional services. But as this model comes to an end, we are thinking about how can we be more expansive in this space? How can we use our authority in the Medicare and Medicaid space And that has certain limits given, healthcare, but also we have partners across HHS, across the federal government. How can we all work together to make sure these patients are getting the services they need and that, are entitled to or are available in their community. So more to come for us on that space as well. Next slide, please. And then just want to, I think this might be one of my last slides, and Medicare Advantage, I sort of talked about that, about, implementing and innovating there. We've had a number of, this model has been going on for a number of years, and the Medicare Advantage program at large has adopted a number of our particular changes as they've changed their regulations. But most recently, as of this year, we are implementing the hospice services within MA and testing that full package of services, because prior to this, hospice had been carved out of MA, and looking at, giving those MA plans, testing when they take on that additional responsibility, what does that look like? Next slide, please. Oh, and I talked about Medicare Diabetes Prevention Program, trying to get the patients to there, and working to make some refinements on that program to make it, make sure it's completely accessible, and our suppliers can come into the program when they're only offering this particular service. Next slide. And then this is the last slide of, looking forward. I know I covered a lot, but as we think about our, where do we continue to invest in models? Can we, CMMI, with our specific authority, do the most good and have the most impact, especially as we seek to keep the patient at the center of all of this, and and try and address those equity issues? How do we do that? There's been a lot of written about CMMI, and a lot of external stakeholders suggesting we have too many models. Where I went through a whole variety of them. They're all, I sort of think of it as like, picking your favorite child. They're all really important. There's so many more we could be doing, but thinking about where can we have the most impact and what can we do. And I didn't actually talk that much about Medicaid. We have a number of Medicaid models, but our authority there is relatively limited compared to Medicare. And so often our models are run in conjunction with our colleagues who run the Medicaid program in our Center for Medicare, CMCS, and we, so there's a, sort of gets to be almost like a multi-payer effort where we have some things in Medicaid, but the Medicaid program and teams in particular states may need specific waivers to go along with that. So we work in conjunction with that, but that is definitely another area we want to continue to build out, and looking at other providers who have not been in our models to date, other areas, clinical areas that there's a great need. We are continuing to be focused on that, and where do we think the incentives are most misaligned, and again, what can we do about that? And then also, integrating innovation across CMS is an important thing. It's kind of maybe a little weedy, or it's definitely operational, but how can we do this? How can we build the Medicare, Medicaid systems to reflect sort of this movement to value, that it's something that we want to continue on with? It's something that is really here to stay. And although, 10 years, long time, short time, depending upon your perspective, we need to build that out and be more nimble and flexible, whether it's like different ways to make payments, looking across provider types, trying to have that, like, both operationally, but also, asking our partners, are there things you could be doing? I mentioned Medicare Advantage. They spent did a deep dive and reflected about how they can change their regulations to be more innovative, to have, really reflect the way care is delivered. And so we're working with our partners across the agency on that in a number of different ways. And so, with that, I know I'm a few minutes longer than I was hoping, but I thank you all very much. I see there's some Q&A already in the chat there. Happy to answer questions, and just thank you all for everything you all do and your partnership. I know when Maura had that list up there, there's lots of familiar names and partners, and so look forward to chatting with you and answering some questions.
Fantastic. Amy, thank you so much. It was fantastic to hear what you all are up to. We do have a number of questions. And so we have roughly 10 to 15 minutes before we have to close out here. So I'm going to run through a number of them. But I'm going to start with, you mentioned earlier that the new administrator has been on for how long again? A month? No.
Oh, just a week and a half.
A week and a half, yeah.
Yes.
Yes, its time is relative at the moment. What does success look like for you all? Do you have this? Like, what 4 years from now, what does this slide deck look like?
Yeah, so I think it looks, there's a number of different parameters or dimensions we would think measure success on. One is more models that have achieved scale, that have met that expansion authority. So we have a new way to pay for primary care, or a new way to look at, any particular services. Maybe it's the kidney care, maybe it's, oncology. That those models have met the expansion. We've learned our lessons. We've been able to find something that works, and we've expanded. We have more providers who are with us on this journey to value. We're more committed, and it just becomes sort of part and parcel of the way we all do business. It's not a side deal. It's not something that's for only X or Y. It's really part of it. And then also that, we are making a dent on the equity side. People are having access. The quality of care for everyone has increased. The access to care has increased. The efficiencies, there's much more efficiencies, far less waste in the system. Very definitely ambitious goals, but we're really hoping that we can make a dent in some of those, given what we know to date and what we have planned.
That's great. That goes into one of the questions here, which is, out of all of the models that have been implemented and tested, is there something that stands out that could be adopted nationwide to shift incentives to improve health outcomes? So as you look at it, is there anything that stands out between different models? And I know it might be compared to apples and oranges, but
it's hard to say across the board, but I think looking at sort of models that have more accountability for the patient, for individuals, not just the whole, here's a whole group of people, but, thinking about every individual being accountable and having, someone looking out for them, and then opportunities where it gives the provider who's taking that accountability, the flexibility to deliver the care and the way they need it. Because, you're in an urban setting, your academic medical centers may be different than rural and, or suburban, or, new to Medicare or Medicaid beneficiary, pediatric. There was so much more I could have talked about of what we've done. So, but just the accountability and the flexibility are sort of the key things I think that even if we've had models that have not met the expansion authority, we can think of still as successful. And all of those models, we've learned a lot from all of them. So there's no models we regret in any way. They've all taught us something really important as we sort of continue to iterate and move forward.
Absolutely. All right, here's a very pointed question, which is, what does the roadmap look like for implementing mandatory models?
Mm-hmm. So all of our mandatory models we've done go through notice and comment rulemaking. So but to step back before we even get there is a sort of internal decision-making process of is this a model that would make sense to be mandatory? Do we have some experience in this space? Do we know what the markets look like, what the providers are, the patient mix? The radiation oncology we decided to do as a mandatory model because realizing that the selection bias was going to be so high. So there's sort of an internal decision process. Every model, it's not every model we're going to do is going to be mandatory, but thinking about how appropriate, how would this work, how big a size of it, and then once we've decided that, having this rulemaking that lays out the specifics of the model, that gives the public time and an opportunity to comment and for us to make revisions on before we then get to implementation. And the implementation even looks a little bit different on mandatory models versus voluntary in terms of timing or data or, partnerships of what we do. So it's, We can write a book on what the roadmap looks like. But first, it's like defining the model, doing the rulemaking, and then specifics on implementation.
Yeah. Okay, questions keep coming in. Everyone keep having them come in. This is great. I'm going up and down based off of our conversation flow. And I want to touch back on the administration's and CMMI's efforts around centering with equity. So this comment is, I really appreciate the administration's efforts to center equity in all of their policy decisions. Value-based care and equity seem to be so well tied together. Can you say more about how current or future payment models will advance equity goals?
So I think we're trying to figure that out specifically, but thinking about some of the dimensions we've looked at, who are the participants in our models? Do these participants represent the population at large? Why are certain populations potentially overrepresented or underrepresented in our models? And so what can we do to address that? What are the, digging down, what are the quality outcomes? How do we stratify in our evaluations to look at that, to look at the equity lens? How does this match up with, other efforts across the agency on equity? Because it's not just a CMI thing, it's really, CMS, HHS more broadly on how we're doing this. And so there's, the quality, the outcomes, the measurement of it, the transparency of it as well. I think just sort of being able to report on what we're finding is, a first step. I think, lots more to come on that, but those are some of the things that we've sort of been talking about to date about ways we can start to address that there. And then there's always designing specific models around it, which, we're still early stages of.
Okay, we have gotten 2 questions around direct contracting. And this is hopefully a pretty quick answer. It says, when do you expect the second cohort application will be for a direct contracting model?
Yeah, we're still working through that. I hope to have some more information to share about the specifics on that, ideally in the coming months, but I don't have a specific date I can share right now.
I want to get that one off the list. Okay, now looking at prevention. You talked about this a little bit on with the diabetes care, with kidney care. This question is, how is CMS thinking about moving forward and preventing chronic conditions through lifestyle changes? Reimbursements and coding for lifestyle medicine, related services for providers, health coaches, etc.
Yeah, that's a great question, and it's a really tough one. I talked a fair amount about Medicare diabetes model. We also have our Million Hearts model looking at cardiovascular. And so in a number of these areas, both in prevention and, home-based services, other places, we have a debate about whether any of those should be standalone models or they should be concepts embedded into broader models. So should there be prevention incentives, indirect contracting to try and create those incentives, or should there be sort of a standalone prevention model? And so we are, sort of at the crossroads there thinking about it, but recognizing diabetes, cardiovascular, stroke, all of these areas, obesity, there's so many different areas that we, would love to be able to delve into more and really use our authority to help move the needle on those areas in conjunction with, like I said, other efforts from, across HHS as well.
All right, I just got notified that I sounded like a robot. Amy, can you hear me?
Sound better now.
Okay,
Yes.
good. It's I know that I'm a little groggy, but not robotic. Oh my goodness. Okay, 2 more questions. 21st Century Cures Act. How do the CMMI models and related use of incentives take advantage of national standards and policy, such as those driven by the 21st Century Cures Act? And CAA / No Surprises Act. Can we talk about that a bit on the thread?
Sure. So we work closely with the, well, first, all of our colleagues who are in the process of implementing No Surprises Act, and we provided them a lot of support just from resources and staffing as they have that tough job to get that done. On 21st Century Cures, we are, there's a lot on the transparency, the data, the IT side of things that we are part of. There's the we think about what the requirements should be in the program versus in our particular model. So it's something that we are working with them on, but I can't say that CMI specifically has done anything there above and beyond what the agency's done. We've just tried to like tweak or target or modify to make sure it works within our models, but for most part those have been sort of agency-wide efforts.
Great. Okay, I am going to ask you the last question. So Amy, it's been fantastic to hear everything that you have going on. And I know that we are just as you said, dipping the toe in the water since the new administration started. Only in a week and a half have you had your administrator. For you, I guess this is a dual question. What keeps you excited about this work? And also what are some of the things that keep you up at night? What are some of the advices, any of your advice for the next couple of days here?
Yeah, so there's so much, and it's just so exciting about all of the people sort of like thinking about this and coming up with all these great ideas, and are thinking about all the work that's been done now with COVID and home services and telehealth. And so just the like volume of effort and the number of people thinking about it who are like so smart and so thoughtful. And so we get really excited about how can we use our authority to like pitch into that and harness some of that, use our voice to help amplify what is going on. So like but then it's also like gets a little overwhelming, and I always feel bad when we're like, we can't do that, or we can't, that's not for us or somebody else. And so I think about, but what really keeps me up about it is the like, if we design a model, I always sort of say like, we're throwing a party. Is anybody going to come to our party? And why? And if they don't, why? What is wrong with our particular model, or why are the incentives not aligned? We know if we sort of spend a lot of money, people will always be very interested, but that's not really sustainable. So how do we design financially sustainable models that can achieve the savings we have, but provide enough incentives that our participants want to come in and make the effort? And change is hard, and to make these changes in a sustainable way. And so it's always the like, did we get it right? One of the good things is, though, we do have a lot of flexibility, so we know in our models, like if something's not working, we can make changes, and in some cases we have to make changes by law. But you don't want to be always having to like tweak, because we also want to be good partners, and like people want transparency and predictability. So the sort of trying to balance all of those, there's always sort of like a little bit of like, you hold your breath about like, is it going to work? And is it going to work because it's like, is this ultimately going to serve patients in the best way?
Absolutely. Absolutely. Amy, any other thoughts before we close out the section today?
No, thank you so much for having me. Thank you for having this event. It sounds really like a fabulous couple days you've got planned, and love to, hear more about it and hear from anyone who's attending. Anything you have for us, we're always open to it, and love to hear comment. And I hope one day, we'll be able to get to do this in person and be together.
We would love that. We would love that. We'll have you out to the West Coast here once everything opens up again. Amy, wonderful. Thank you. And thank you for your work. We look forward to seeing you.
Thank you so much.
All
See
right.
you soon. Bye.
All right, everyone. Thank you for joining us this morning for our keynote. It was great to hear from Amy and what CMMI is doing. I hope that we can take these learnings throughout the next day and a half with us. This is, I love the idea of the party. So what snacks are we going to bring? How do we make sure that everyone joins us in at this party? Okay, we're going to transition. We're going to take about a 15-minute break. I'm looking at my notes here. We're going to take a short break, about 15-minute break. And then when you log back on, take a look at your attendee guidebook, you will have a link for our next section. This next section is going to be, I'm really looking forward to this next section. We have Dr. Bob Crittenden and Dorothy Teeter joining us to cover the history of the incentive structures. I'm probably going to go drink 2 more cups of coffee before this. This is going to be a lot of information, but again, really, really critical information as we move forward in the next couple of sections. All right, so we're logging off here. We will see you at our next Zoom link. Take a look at your attendee guidebook for that next Zoom link and see you all in 15 minutes. Thank you.